All right,
Okay,
thank you
the
very much.
recording has started.
Great, thank you. Good morning, everybody. This is Dr. Helene Calvé. I'm the Deputy Medical Director for Communicable Disease Control at the Orange County Healthcare Agency. I am board certified in internal medicine and infectious diseases, and since March of last year have been pretty much full-time doing COVID response. I'm in charge of the long-term care facility team, which has responded to over 250 outbreaks, COVID outbreaks in skilled nursing facilities and residential care facilities for the elderly. The reason for this webinar, I think it's probably obvious, but in the last several weeks, I've seen when responding to outbreaks, a number of facilities where medical directors or private doctors have just been prescribing medications that may be harmful. So at that time, I brought up the issue with Dr. Robinson, who is part of Expert Stewardship, a group of infection prevention specialists that the county contracted with to help us in our response. This issue for him is also a very serious problem, so he graciously agreed to present on this today. We also have with us today Dr. Matthew Zahn, who will be speaking briefly on a vaccine update. So we'll start with Dr. Robinson. He is nationally recognized in his field. He's the medical director of infection prevention, hospital epidemiology, and antimicrobial stewardship at the Hoag Hospital and Hoag Orthopedic Institute. He is co-chair of the Providence St. Joseph Health Infectious Disease Clinical Decision Team and a fellow of the Infectious Disease Society of America. He's an executive director and founder of an organization which implements and manages antimicrobial stewardship and infection prevention programs in long-term care facilities, and that's Expert Stewardship, which I referred to. They've been a tremendous, tremendous help in our effort to respond to outbreaks. Dr. Robinson was invited to serve on state and national committees and is currently the immediate past president of the Infectious Disease Association of California and the past chair of the Healthcare Associated Infection Work Group of the Hospital Quality Institute of the California Hospital Association. He also serves in a leadership capacity in the Infectious Disease Society of America. He works closely with the California Department of Public Health, the Orange County Healthcare Agency, and the Centers for Disease Control and Prevention. Dr. Robinson received his medical degree at Michigan State University, College of Human Medicine. He completed his infectious disease fellowship at USC LA County Medical Center and internship in internal medicine at Harbor UCLA Medical Center. Dr. Robinson's research interests include topics related to infection prevention, antimicrobial stewardship, COVID-19 infection, including therapeutics and vaccine development, fungal infections, sepsis, and malaria. Dr. Robinson is the principal investigator at Hoag for the Gilead COVID-19 remdesivir clinical trials, the Roche COVID-19 clinical trial, and the sub-investigator for the expanded access to convalescent plasma for the treatment of patients with COVID-19. He will also be the principal investigator for 2 upcoming vaccine trials. We're very fortunate to have Dr. Robinson, a true expert in his field, to speak to us today about COVID treatment. Thank you, Dr. Robinson. Take it away.
Well, thank you very much, Dr. Convey. Very, very kind and warm introduction. I appreciate that. It's always, I'm honored to be able to have this opportunity to talk to this group. And what I'd like to do is, something's happening here with annotated requests I'll get rid of. I like to always start these types of presentations with a case report. This is a case that was seen at one of our hospitals in January. This case has actually become pretty common for us to see. It's a 78-year-old male, have really metabolic syndrome, a little bit of type 2 diabetes, hypertension, hyperlipidemia, who developed a flu-like syndrome on the first day of 2021. 2 days later, he got tested and was COVID positive. At that time, he was not on supplemental oxygen, and his primary care physician decided to initiate treatment. That treatment included a combination of dexamethasone, Levaquin, hydroxychloroquine, ivermectin, and a combination of vitamin C, vitamin D, and zinc. Unfortunately, none of this helped the patient. He did have issues with some nausea, some vomiting, a decreased appetite, and eventually progressed to respiratory failure. You can see his chest x-ray I'm displaying here that shows a pretty typical pattern associated with COVID pneumonia. When he came in to the hospital, he was placed on high flow supplemental oxygen. And unfortunately, he also had hepatitis. So his AST and ALT were both greater than 10 times upper limit of normal. And because of that, our treatment teams were unable to prescribe remdesivir. The EUA for remdesivir requires that LFTs be no higher than 10 times upper limit of normal. And in looking at this case, I became concerned that his treatment that he received prior to his admission to the hospital probably contributed significantly to his elevated liver function tests, and in the end may have harmed this patient and preventing him to get evidence-based therapy. And this isn't the only case that we have seen. Talking with my peers throughout the county, as well as Dr. Calvé, and kind of looking at our admissions over the last few months, about a third of patients that are admitted to our acute care hospitals are on non-evidence-based therapies. And some of these therapies have resulted in toxicity, and as I mentioned in this particular case, preventing us from starting the patient on evidence-based therapy, and including preventing us from enrolling some of these patients into clinical trials. And in a few cases, treatment in the outpatient setting has delayed patients' presentations to the hospital. And they have then come in maybe a little bit worse than they would have if they had sought medical attention earlier. Oh, there we go. Still getting used to advancing the slides. Now, these treatments that this patient and many others are receiving prior to admission to hospital are really a response to the lack of data of treatment in patients in the outpatient setting, as well as very preliminary non-evidence-based guidelines, such as one example here is the one I'm showing on the screen from the American Journal of Medicine. This particular guideline is promoting the use of antibiotics and hydroxychloroquine in a subgroup of patients. And I want to point out, if you look at this guideline, right up front, it says that this guideline is based on pathophysiological principles. And in my book, that's code for no evidence. Expert opinion, best guess, biological plausibility, which is all very fine, but none of this, unfortunately, is substantiated by any rigorous scientific data. And the guidelines themselves recognize that and also recognize that future randomized controlled trials are really needed in this particular space. So what I'm going to do is really spend most of my time going through those evidence-based guidelines. California Department of Public Health really refers mostly to the National Institutes of Health, or the NIH guidelines, but there are several other guidelines out there, including ones from IDSA, the Infectious Disease Society of America, and the World Health Organization. I'm going to kind of rely pretty heavily on the NIH guidelines because CDPH and CDC really just refers readers to them. It's not that the other guidelines aren't any good. All of these guidelines really do a good job about going through the literature and analyzing the data behind these recommendations so that the provider that's using these guidelines really has a good and a full appreciation of how those decisions were made. So the topics I'm going to focus on, and again, it's going to mostly be outpatients because that's where the biggest opportunity has been. Most patients with COVID, of course, are outpatients, thank goodness. We're going to talk about the commonly prescribed outpatient treatments, steroids, antibiotics. We'll talk about the drama surrounding ivermectin, vitamins, and zinc. We'll spend quite a bit of time looking at individual studies. In this short period of time, however, I'm not going to be able to get into any detailed discussions about all the studies. So I picked a few that sort of are really good at the pro-con argument. And then we'll talk about some of the newer outpatient treatments. And then, as Dr. Calvé mentioned, Dr. Zahn will finish up with an update on vaccine. And then we'll have time at the end, hopefully, for some Q&A. So I'll have you save your Q&A for the end, please. So this slide here is a great summary of the disease progression in COVID from, on the left, exposure all the way over through severe critical illness into recovery. And I've drawn a big red line somewhere in the middle there to really delineate sort of the 90% of patients that stay in this, what we'll call the viral phase. Most patients, COVID is a very mild disease. It acts very much like an influenza-like illness. And only about 10% of patients will end up in the inflammatory side of this chart. And usually that occurs on average of about day 8. So if somebody has the sniffles, some low-grade fevers, muscle aches and pains, and a little non-productive cough, again, 90% of those patients will probably by day 8 or 9 be feeling better and not progress to the inflammatory phase. But about 10% of patients, their immune system kicks in, perhaps a little bit too exuberantly, and they enter the inflammatory phase, which is really manifested by the development of pneumonia and the requirement for supplemental oxygen. It's really important to keep this concept top of mind because some of the interventions that we use in the inflammatory phase will not work in the viral replication phase. In fact, some of those that we use in the inflammatory phase may actually make things worse if we use them in our outpatients that are just experiencing the viral phase. One great example of that we'll discuss in more detail in a few minutes is steroids. So let's start by looking at the literature. Dr. Calvé mentioned that I have a great interest in antimicrobial stewardship, so I thought maybe we'd start out discussing the role of antibiotics in particular for COVID. And I think really the rationale that many providers use to justify antibiotics in patients with COVID-19 infection really is our experience with influenza. But influenza is not COVID-19. And I've got a few slides to really try to convince you that the possibility or the probability of a secondary bacterial co-infection in patients with COVID-19 is really a lot less than influenza. This particular study by Morens in 2008 looked at hospitalized patients with influenza and found that up to about 35% of those folks actually had a secondary bacterial infection. But what is the rate of bacterial co-infections in COVID-19? I'll discuss that in the next few slides, but really the dangers of using antibiotics is something I've got to point out first. And the bottom line is that any antibiotic really has no effect against SARS-CoV-2, the virus that causes COVID-19. And that overuse and unnecessary use of antibiotics is really driving our epidemic of multi-drug resistant organism as well as Clostridium difficile. Oh boy, I've got myself goofed up there. Okay, there we go. Sorry. And these are just a couple examples of how the lay press has really picked up on this, quote, superbug issue as well as C. diff. At our acute care hospitals, we are starting to begin to see an increase in C. diff rates, and part of that is certainly driven by antibiotics given to patients with COVID prior to their admission to the hospital. So the use of antibiotics in COVID-19, our expert panels, the World Health Organization, and others recommend against the use of antibacterials in patients with mild or moderate COVID-19. And these are patients that would fall in that viral phase in the outpatients. Again, antibiotics have no effect against SARS-CoV-2. The guidelines do give us permission to go ahead and start antibiotics for patients who are suffering from severe COVID-19. Those are patients, by definition, that would be admitted to the hospital on supplemental oxygen when there is a suspected bacterial infection. And I want to pause there for the inpatient doctors that may be listening. Many of us will look to laboratory values to decide whether or not somebody has a bacterial infection. And two laboratory values that we typically look at are white blood cell counts as well as procalcitonin if your lab has that capacity. Unfortunately, with COVID-19, both leukocytosis and an elevated procalcitonin are very, very common in hospitalized patients with COVID. So unfortunately, both of those lab values are really unhelpful to try to sort out whether or not a COVID patient may be secondarily infected with a bacteria. If antibiotics are started in patients with COVID-19, certainly you want to do a further investigation, check that sputum, get some cultures, and if you convince yourself in the next day or two that bacterial infection is less likely, and you're only really seeing a syndrome consistent with COVID-19, stop that antibiotic as soon as you are in that situation. Save your patient several days of unnecessary antibiotic exposure. So what is the incidence of bacterial co-infection in COVID-19? Here are several studies. I'll go through them real quickly. Rawson, despite 72% of over 2,000 COVID patients being admitted to the hospital receiving antibiotics, only 8% of those were actually determined to have a co-infection. In a study out of Italy, almost 17,000 patients who died of COVID infection, only about 11% of those cases were determined to have a bacterial superinfection. In Wuhan, a small study of sick patients who actually went on to, many of whom, about half of them who died, only about 15% of those had a bacterial infection. But those really are the sickest of the sick. When you look at a meta-analysis by Lansbury, there were 31 studies included in this analysis, almost 4,000 patients. Again, hospitalized patients, so these are the patients that are on the sicker side of that scale. Only about 7% of those were determined to have a bacterial co-infection. Bacterial infections really in patients in the outpatient setting are very, very, very uncommon, certainly much less common than those patients that are hospitalized. So what about early antibiotic use in COVID? Does it change outcome? Here is a study that looked at a relatively small study early in the pandemic that looked at 48 ICU patients and looked back to see whether or not administration of antibiotics prior to their admission to the intensive care unit made any difference. 40% of these patients did get antibiotics as an outpatient. Augmentin was one of the most commonly prescribed ones. And when you looked at mortality, that the intervention of antibiotics did not affect mortality.
Okay.
So that's why the guidelines recommend against
Everybody, please mute yourself.
Bacterial infections in outpatients and only really reserve it for the sickest patients in the hospital. So let's pivot a little bit to other antimicrobials, anti-malaria medicines, and azithromycin in particular. So talking about chloroquine or hydroxychloroquine with or without azithromycin. The guidelines very strongly recommend against the use of these agents, either singly or in combination, and that's based on multiple randomized controlled trials. At least 5 good randomized controlled trials, and at least 4 observational studies. The NIH website gets updated continuously with new information, so please continue to check back. These slides were developed over the last couple of days, and I wouldn't be surprised if one look back, there might be some more data. But here are some studies that have informed this recommendation. The recovery trial out of the UK, over 7,500 hospitalized patients. There was no significant difference in 28-day mortality. And there was a trend actually for longer hospitalization and increased risk of mechanical ventilation in patients that received these interventions. In Brazil, there was an open label trial, over 500 hospitalized patients, and neither hydroxychloroquine alone or hydroxychloroquine with azithromycin improved their outcomes at day 15. And there was an observational study done earlier this year out of New York with almost 1,500 hospitalized patients. And in that study, they noticed that those patients that got a combination of hydroxychloroquine and azithromycin were associated with an increased risk of cardiac arrest. Randomized placebo-controlled trial looking at hydroxychloroquine in outpatients with early COVID-19 that was conducted both in Canada and the United States. Patients had to have symptoms less than 4 days. There were over 400 participants. There was no significant difference in their outcomes at day 14, except that there were a significant increase in adverse effects, mostly gastrointestinal side effects in the treatment groups. This outpatient open-labeled randomized controlled trial out of Spain, almost 300 patients, showed no difference in viral load reduction, no difference in hospitalization, and no difference in time to recovery. But again, they did notice that there was an increase in adverse events in the treatment group. Now, some of you probably recognize that I'm moving through these slides very, very quickly. I'm doing that so that we have time at the end for Dr. Zahn and questions and answers, and also with full knowledge that this is being recorded, and you'll be able to go back and look at these slides and listen to the recording slower if you would like. I'm going to turn my attention now to ivermectin. This has really become quite a hot topic, and there's a lot of drama surrounding the use of ivermectin. So again, we want to go to the guidelines and really take in the evidence that either is for or against these. So the NIH panel just changed their recommendations last week. The current recommendation states that there is insufficient data to recommend either for or against the use of ivermectin. Prior to this update, the guidelines recommended simply against ivermectin. So more data is accumulating, but there really isn't enough data to recommend this for COVID-19, either in the outpatient or the inpatient setting at this point. Ivermectin, of course, is FDA approved. It's an anti-parasitic drug used mostly for roundworm infections and scabies and other such things. I want to be very clear that there is no emergency use authorization to use ivermectin in the treatment of COVID-19. There is some scientific plausibility about why this might be helpful in COVID-19. It is an inhibitor of the nuclear transport proteins, in particular imporin, that is used by SARS-CoV to enter cells. And if you try to culture SARS-CoV-2 virus in the presence of ivermectin, it doesn't replicate very well. So there's some in vitro data that there might be some activity. But when you really start to look at those studies and you realize that in order to affect that type of inhibition of replication in a human body, that you would really need over 100 times higher doses than those that are currently approved for human use. So giving a few tablets of ivermectin to your patients with COVID is likely not to really cause any significant reduction. Yeah, some clinical studies have shown that there's no benefit. In fact, some have shown that there's actually worsening of disease, not dissimilar to the patient that I described at the beginning of this talk. But some studies have shown a shorter time to resolution, a reduction in inflammatory markers, and shorter time to viral clearance, but no real clear signal in mortality, which I would argue is probably one of the most important outcomes that should be looked at. And most of those studies, both the pro and the con studies, really had some serious methodological issues, incomplete information, limitations on concomitant medicines, and in particular, the use of corticosteroids, which in many of the studies became a confounding variable. We also don't have any idea which patients would be best to benefit from this, if any, where in their disease, what doses to use, etc. And it's also not without risks. I described the patient at the beginning that developed a pretty significant hepatitis. Part of that was likely driven by ivermectin, but ivermectin has been associated with severe skin rashes, nausea and vomiting, limb swelling, neurological adverse effects, hypotension, and of course, if we use ivermectin for all of our COVID patients, we'd probably be facing drug shortages for those patients that would need it for their parasitic infections. Real quickly, what's the evidence behind vitamin C, vitamin Z, and zinc? The guidelines recommend neither for or against the use of vitamin C or vitamin D, but the guidelines do recommend against using zinc supplementation. The reason for that, again, is that there are no good randomized controlled trials that show a benefit, and there can be risks, even with vitamins. So even something that is innocuous sounding as vitamin C and D, there can be significant drug-drug interactions, can affect the absorption of other medicines, and also I've seen patients develop GI side effects, and you know, some of these vitamins do come with a cost as well, although not all that high. For zinc, in addition to all of those, we have to worry about reports of reversible hematologic deficits like anemia and leukopenia, and then there's a small possibility of some permanent neurological manifestations that can develop after longer use. Usually that doesn't develop until after months of using zinc. One of the most common interventions that I'm seeing, if they're not on the vitamins, if they're not on ivermectin, many outpatients are being admitted to the hospital having been exposed to corticosteroids prior to their admission. So I really want to drive, of everything that I'm going to talk to you about today, this is probably the lowest hanging fruit. I want to review the data on dexamethasone and COVID. So if you look at the middle chart, this is a Kaplan-Meier curve that shows the percent mortality compared to days since randomization in these trials. And this, again, is that UK trial, the recovery trial, that had many thousands of patients. And those patients that were requiring oxygen, that's that middle panel, and there were almost 4,000 of those. If they got dexamethasone, you can see that their mortality curve was quite different from the mortality curve associated with usual care. And that difference was and that was statistically significant. And on the right, if you look at those patients requiring mechanical ventilation, you can see that those curves diverge even further. Again, a statistical difference favoring mortality. This is the only drug that has been studied in COVID to actually show a reduction in mortality that's statistically significant. However, we have to be careful because you can't give dexamethasone, Decadron to everybody with COVID. I want to draw your attention to what I've circled on the right. Same trial, same data. Patients who were not receiving supplemental oxygen, the curves are flipped. So in patients who are not on supplemental oxygen, there was a trend towards increased mortality. I'm convinced that some of the patients that were admitting to the hospital who got dexamethasone, Decadron, prior to their admission to the hospital when they were just in that viral phase, that those steroids may have caused that virus or may have given that virus permission to perhaps replicate more and end up causing more damage than harm. So again, the point here is only use dexamethasone in patients that are admitted to the hospital on supplemental oxygen. This is not a treatment for outpatients. One other thing is 10 days is enough. The guidelines support 10 days. That's based on the research that I just outlined. Any more than 10 days, you begin to see issues with secondary infections, both fungal and bacterial. Real quickly, let's talk about remdesivir. I was really excited to be part of some of the early clinical trials with remdesivir. This particular trial here looked at over 1,000 patients and compared their percent recovered, not mortality, but percent recovered over days. And just like in the dexamethasone, you can see that there is a benefit, a statistical benefit. But again, I want to point out that this is time to recovery. There's about a 30% reduction in time to recovery in patients admitted to the hospital on supplemental oxygen, but there is no effect on mortality. That's all we really know about remdesivir right now, that it shortens time to clinical improvement. It doesn't really help that much in patients admitted to the hospital in more advanced stages of the disease, for example, those on high flow mechanical ventilation or ECMO. 5 days is enough. Again, no effects on mortality. But the question that we have to answer is whether or not early remdesivir might actually prevent somebody from progressing to requiring supplemental oxygen or being admitted to the hospital. There is a clinical trial that is now beginning to enroll. I've got the information on the bottom left of this slide. It's a Gilead-sponsored trial. It will be a randomized, double-blinded, controlled trial looking at the effect of 3 days of remdesivir compared to placebo in outpatients at risk of progressing, but who have not yet progressed. So really excited about answering that question. I am frequently asked whether or not, somebody, a medical director in a skilled nursing facility or perhaps in an outpatient infusion clinic should be prescribing remdesivir in this setting. It's hard for me to support that right now without any clear data. And also want to point out that remdesivir is pretty expensive. For 5 days, it's just over $3,000, and that's just the cost of the drug. So we need to get the data on whether or not it actually works before we recommend an expensive therapy like that. Next thing real quickly are the monoclonal antibodies. There's bamlanivimab, which I've learned to pronounce. That's a picture of that is at the top right. There's also the Regeneron product that I will not attempt to pronounce. That's a combination of 2 different monoclonal antibodies. The table 4 at the top on the left shows the data that triggered the FDA emergency use authorization for this product. When you look at the 700 milligram dose and you compare it to placebo in patients that are at high risk for hospitalization, those are typically patients that are over the age of 65 or have a BMI greater than 35. You can see that their risk for hospitalization or need to visit the emergency room was cut from 10% to 2%. And similar data, having the rate for admissions was demonstrated also for the Regeneron product. The NIH guidelines, however, do not feel that this data raises to the level of actually being able to recommend this therapy for patients with COVID at this time. That said, there are many areas throughout Orange County where monoclonal antibodies can be accessed. Several emergency rooms have protocols in place that will allow patients to come to them for care who do not meet my criteria for admission but do meet criteria for the EUA. They can get that drug administered in the emergency room or referred to in infusion centers. And I believe there are also at least 1 or 2 infusion centers throughout the county. Sure, skilled nursing facilities, PACE, and prisons are really ideal settings for administrations of these monoclonal antibodies. There's a high prevalence of high-risk patients in these populations, and they get tested frequently, so an early diagnosis can be made. For those of you who have the ability, the time, and the fortitude and desire to do this, you can reach out to several specialty pharmacies. I've listed the current specialty pharmacies that have been given state allocations of these monoclonal antibodies as of a couple days ago. If your facility contracts with those, they could, in theory, prepare and deliver the drug to your facility. That is unfortunately not the easy part. The hard part is actually developing a safe process to administer these products in your population. So I would refer you, if you are at all interested, about doing that for your patient population. I would refer you to this Operation Warp Speed Therapeutics monoclonal antibody playbook. The link is at the top left. If you just Google those words, you'll come right to it. I pulled a few pages from that playbook. First off, noting who would qualify for getting these agents. Number one, you have to be diagnosed with COVID. You have to have a syndrome consistent with COVID, and you have to have a positive diagnostic test. It doesn't require just a PCR, but an antigen test in the right clinical circumstances is more than enough. These monoclonal antibodies have been shown to work in the first 10 days of symptoms. So again, these are patients that are in that viral phase of illness, not the inflammatory phase. These products are not to be used in patients who are admitted to the hospital. And remember that I showed you that there was a nice decrease in the rate of patients that require emergency room care or admission to the hospital in high-risk patients. Again, that would be the best population to target. And again, those are aged 65 years or greater and a BMI of equal or greater than 35. This screenshot from the playbook really talks about the whole process, and it really takes a team to do this. You've got to have an engaged physician with expertise in this area who is certified in ACLS or at least BLS in case there are side effects. These products are not benign. About 1% of patients do develop an allergic reaction. You have to have a pharmacy that is capable of preparing it and delivering it to the site of infusion. And then you have to have qualified nurses, and usually this takes a couple nurses to do. The infusion goes in over an hour, and then you have to monitor the patient carefully within an hour and have easy access to rescue that patient if they do develop a side effect. And here's the readiness checklist from this playbook. I'm not going to go through this except for saying you need a good dedicated space with patient flow management, good source of supplies, in particular everything you would need to treat somebody if they had an allergic reaction, sufficient personnel, and a process in place to do this safety. And I'm going to conclude my last slide or two on really summarizing the National Institutes of Health recommendations. We really focused mostly on the outpatients, that very top rung on this ladder. And really there isn't much. None of the data supports really anything except maybe a consideration of these monoclonal antibodies, and specifically calls out not using dexamethasone in that population. And again, just a zoomed in screenshot of those particular outpatient recommendations. It's not that there isn't anything to do for these patients. There is a lot to do. Most of these patients are going to do just fine. They require reassurance, respiratory monitoring, and depending on the patient, that could be anything from having one of your staff check on them to actually using telemedicine to monitor their saturations and the respiratory rate, and really symptom control. Reassurance, monitoring, symptom control really is the hallmark. And some patients considering monoclonal antibody, certainly considering patients for clinical trial will always help us move the science forward. And then I just listed here at the bottom some criteria for those outpatients that you might want to consider when deciding whether or not they might need to be referred to evaluation in ED, urgent care, or admission to the hospital. So severe dyspnea, oxygen saturations at room air of less than 90%, regardless of the severity of their dyspnea. And then alterations and mentation, signs or symptoms of hypoperfusion or hypoxia, such as falls, should all be part of that decision. And I'm going to land it there, and I'm sorry, Matt, I probably ate into some of your time, but I'll go ahead and let you take over from here.
Thank you very much, Dr. Robinson. That was an excellent presentation. And everybody, this is being recorded. We will post it on the OCHCA website along with a PDF of the slides. We will send out information on how to access that probably by Monday, if not before that. Dr. Zahn, you want to, or Danica, can you, since we're running late, are we able to go overtime on this to answer questions? Because I'd like to, there's a number of questions that have come in we'd like to address.
Yes, I don't believe we have a time limit, and I just handed Dr. Zahn so he can start presenting. Yep, you got it.
Right.
Yeah, I don't think we have to be done exactly at 12.
Okay, great. So if people are willing to hang in a little bit longer, please put your questions in the chat box, the lower right-hand side where it says chat. Go ahead and put it in there, and I'll read those off as many as we can get through. So Dr. Zahn, Dr. Matthew Zahn is a colleague of mine. We've worked together for the last 10 years. He went to medical school and residency at St. Louis University, did his fellowship. He's board certified in pediatrics and pediatric infectious diseases. He did his fellowship at Colorado Children's Hospital, and then was PEDS ID faculty at the University of Louisville, where he also worked at the local health department. And now he has been our medical director of communicable disease control here in Orange County since 2011. Take it away, Dr. Zahn, and everyone please mute if you became, I heard a little bit of noise last time, so make sure you're on mute. Thank you. But Dr. Zahn, you can unmute.
Can you hear me now?
Yep, we can hear you now.
Yep. Okay, perfect. Thank you, Helene, and thanks, Dr. Robinson, for that fantastic presentation. So I just have a few slides here to talk about a few clinical updates for COVID-19 vaccine as this information comes in, and we'll try and get to everybody's questions as quickly as we can. So just big picture here in Orange County. As of yesterday, our total count of identified doses given of vaccine in this county is a little over 108,000 doses, and this is on our website. You can follow it daily. So I would take two things from this. One is that 108,000 doses is not a trivial amount, so the system is vaccinating people. At the same time, I think we all have the recognition that this vaccination process has been going on for weeks already, and we have over 3 million people in the county, around 3.2 million people in the county. It signals that the vaccination process is going to go on for weeks to come. We have no indication on the federal level that the vaccine supply is going to slow down. On the other hand, there's not a lot of evidence that it is going to speed up, and so this is sort of where we are for the weeks ahead. More vaccine, but not as much vaccine as we like. In terms of who is recommended to be vaccinated in Orange County, and this largely mirrors, but not completely mirrors, CDC initial 1A guidance. The two that are easy are healthcare personnel. And now for the healthcare personnel, again, can't emphasize enough with limitation on staffing, limitation on amount of vaccine out there. We really want to target vaccination to healthcare providers, not just medical strictly, but also environmental or staff, but people who are coming in contact with patients on a daily basis. That's really the goal. Then number three, residents and staff of long-term care facilities have been from the beginning an emphasis. And also in Orange County, we've recommended persons 65 years of age and older be vaccinated. In full disclosure here, I think it's becoming a relatively not incredibly well kept secret. The California Department of Public Health is likely to release additional guidance statewide as to who should be vaccinated. We anticipate that this will be really focusing on what we already kind of doing in Orange County, vaccinating people 65 years of age and older. But I would tell you all, be aware, keep an eye out for the next few days for California Department of Health, Public Health recommendations, because those may provide additional guidance to how we are going to be responding. And no, I don't know more than that. That's about really what I know. We're waiting for the guidance like everyone else. In terms of where we can provide vaccine or where you can get vaccine in Orange County, again, adult residential care facilities, skilled nursing facilities have really been plugged in, and now assisted living and other residential care facilities are receiving vaccination as well, again, through a federal partnership with CVS and Walgreens, who are those pharmacy staff are the ones who are largely conducting these outreach and vaccination to these facilities, and we're incredibly appreciative for that. Hospitals and hospital systems have begun receiving vaccine, both to vaccinate their staff and to begin vaccinating their patients who qualify as well. Dialysis clinics and some clinical sites in our community are receiving vaccines, but I would caution that, general community sites, we just don't have a huge number. We're trying to be targeted because of limited doses of vaccine. I think anybody who pays attention to the news know that there are large point of distribution pod sites. One is already going at Disneyland, picture to the right, and Soka University in Southern County is going to be setting up a point of distribution site as well. The goal is to be offering upwards of 3,000 doses a day in those at those sites. We are also on a very limited, targeted level trying to provide mobile clinics to reach senior citizen community sites to get vaccinated. How do people sign up to get vaccinated? If you go to our website, the OCHCA website, they can take you to the Othina website to get vaccinated, to get signed up to receive vaccine. And Othina also offers an app that you can download and that you can use to sign up. To be clear here, I think we're all experiencing a degree of frustration with the process. I mean, the number one primary issue here is we simply don't have enough vaccine to vaccinate even the very high-risk people in the community that we really want to get to as soon as we can. I mean, that is the underlying issue. I will say that we've certainly received a lot of feedback and concern and angst for working through the Othina app itself. I can only say we hear you. On a broader level, I'd say that setting up a system that has been able to register over 250,000 people when the system didn't exist a couple of weeks, or a couple of months ago is quite an achievement. At the same time, people have had issues trying to register into Othina, and then once they've tried to sign up in Othina, have had issues in terms of having confirmation that they're in fact in the system. We've certainly heard those concerns. It's frustrating to us, to have issues with that system as well. And I can just only tell you we're working as hard as we can with Othina to make the system work as well as it possibly can for people. But we know there's been some bumps in the rollout as is not a huge surprise, and unfortunately, as we go forward. If for all providers who want to be able to vaccinate their patient population, if you go to this, it's a California website, www.calvax.org, or if you just look for Calvax on the web, you can go there and sign up to be a potential provider of vaccine in the community. As you can imagine, with limited vaccine supplies, merely signing up is not a guarantee that you're going to be receiving a vaccine to be able to vaccinate your patients. Certainly, we want to roll it out as soon as we can, but the limitations mean that we certainly encourage people to sign up for their clinical site to potentially provide vaccines, and we look forward to the point where we can distribute the vaccines more broadly as more vaccine becomes available. So a few additional recommendations, updates here, and I guess I skipped by the obvious, which is there are 2 vaccines that are out there. Moderna vaccine, a 2-dose vaccine, they're given 28 days apart, and then Pfizer vaccine, which is a 2-dose vaccine with the vaccine given 3 weeks apart. There have been a lot of questions about, well, when do you give the second dose, and particularly with a shortage, how long can you delay that second dose? And last night, the CDC released additional guidance beginning to address this issue. One is that the comment remains the same, which is that for Moderna 4 weeks, Pfizer 3 weeks, as much as possible, we'd like to adhere to that regimen and give the second dose in that interval. If because of shortages or other issues there's a delay, the CDC essentially said that if you delay the second dose to 6 weeks, that 6 weeks applies to Moderna or Pfizer, 6 weeks after the first dose is given. By all clinical understanding and what we can see from the studies that are out there, this should be perfectly acceptable. So it's at least giving us a window of saying if you delay the dose till at least 6 weeks, that does certainly still seem to be reasonable. If you get past that, 8 weeks, 10 weeks, 4 months later, if you have to delay that vaccine because of shortage or whatever reason, there's just less data indicating how effective that regimen is when there's that sort of longer interval. That's not evidence to say that if we give the second dose to someone 4 months later, that there's evidence that it won't work, or even really good reason to think that it won't work. It's just that the trials out there really haven't studied that at all, and so we want to be careful about saying what we know exactly. If you end up having a more lengthy interval between doses, there's not a recommendation to revaccinate or start the series over, as just with all the other vaccines, same recommendation. Side note for Othina, for people who sign up, the goal is going to be to get people assigned a follow-up second dose automatically within the Othina process. Second other guidance that came out overnight. So the other question is, well, if you've had disease, then should you or should you not get vaccinated? Well, the first comment is there really isn't a contraindication to getting vaccinated unless you are actively sick, meaning for the 10 days after your symptoms start, when you got to be in isolation, we don't recommend that you get vaccinated. If you test positive but are asymptomatic, you shouldn't get vaccinated for the 10 days after that positive test. Basically, the time while you're infectious, you shouldn't get vaccinated. As much as anything, that recommendation is to assure in a clinical situation someone doesn't show up and infect people. But I just copied out the entire CDC comment just to make sure that clarify exactly what they're saying. There's no recommended minimum interval between infection and vaccination. And current evidence suggests that the risk of reinfection is low in the months after initial infection, but may increase with time. So this is saying that you may choose to temporarily delay vaccination, but there's no clinical reason why you should delay vaccination. There's no evidence that you've been infected, that the vaccination, you'll have an enhanced immune response or more significant issues from the vaccine because you've had disease before. The trials gave people vaccine inadvertently who'd had infection previously, and there was no evidence that those people in the trials had any kind of significant reaction after vaccine. So clinically, you can do it. You may want to delay. The one big thing I take from this actually is that for those of you paying attention, the CDC has been saying, well, if you got COVID, how long before you're much less likely to be immune? Or how long can you think you probably are immune? For a while, we've been saying 90 days, 3 months. This comment, I think, is the first time the CDC has started saying, yeah, that's not just 3 months, it's probably months after that. They're not going to say 6 months, they're not going to say 9 months, they're not going to give us a period of time, but I think they're specifically saying we're not going to say that it's just limited to 3 months. What they're saying is, at least right now, your chance of getting reinfected after an infection for several months, many months after your infection seems to be quite low. I'll note the one thing at the bottom, reinfections do happen, though rare, and certainly if you're in high-risk settings, if you're a staff person working at a nursing home, you should still get vaccinated even if you've had recent disease because reinfection does happen, and people in high-risk settings, there's no risk to it and to getting vaccinated after disease, and so why not give yourself that additional protection? Couple other things. One is that you may have heard that there were 6 cases identified in a short period of time in a San Diego and 1 drive-through site. And these cases were reviewed, and it was a big issue for us in California because 1 lot was associated with this event, and the state of California held the lot pending this review. A couple of things that I know. One is that it really weren't anaphylactic events, full-on anaphylactic events. They were peripheral angioedema events that were noted. Not clear why all these events seem to happen in a short period of time. It's admittedly peculiar, but no obvious reasons why that's so. The vaccine has continued to be given at multiple other sites in California and other states without any issues, and it's been released. I think that one big thing I took out from this event is that all the persons, those 6 cases, they all had issues within 30 minutes after being vaccinated, and several of them did indeed have a history of allergy, and this has really been seen both for Moderna and Pfizer vaccines. You'll see anaphylactic type or immediate reaction type angioedema and other type events for people who have a history of significant allergy, particularly to injectable therapies or to vaccines in the past. Those are the people who are at risk. And actually this morning, the CDC just released data on the Moderna Pfizer vaccine. Based on their surveillance, it seems that 2.5 cases per million doses of Moderna vaccine of anaphylaxis are identified per million doses of Moderna vaccine. For Pfizer vaccine, their estimate based on surveillance is 11 cases per million doses. Background for flu vaccine, for example, it's about 1 in a million cases of anaphylaxis. So for both vaccines, there seems to be a higher risk than your average vaccine for anaphylaxis. So be prepared to have everybody wait for 15 minutes and be monitored. People who have a history of immediate allergic reaction to vaccine or injectable therapy or history of anaphylaxis for any reason should be monitored for 30 minutes. And you got to have epi ready and able to use. So we have to be mindful of that. But otherwise, it sure seems like these vaccines are seeming to be safe. Would note that as we're having more and more people get the second dose of vaccine, the side effects, and the trials they saw this too, systemic side effects, fever, chills, tiredness, headache, really do happen and particularly are prominent after the second dose. They happen about within 48 hours. You don't have other URI stuff, cough, sore throat, and stuff like that. Those symptoms don't overlap with COVID, but certainly be prepared for this. In particular, if everybody in your clinic is going to go get a second dose on the same day, you might want to avoid that because everybody might be feeling kind of not so great for 24 to 48 hours after they receive that vaccine. These aren't serious things. They're unpleasant, and just be ready and aware. I'll go ahead and stop there, and I'm happy to take any questions. I will tell you, I terribly appreciate Dr. Robinson's presentation. Sorry, I'm running a bit late here. I would comment that please, I would, if you have questions or constructive criticism about the vaccine rollout process, this is my email. I'm happy to receive it. If you have constructive criticism or just criticism about the vaccine rollout process, feel free to send them to me. But I really would like the questions to center on, particularly the clinical issues and obviously the clinical issues Dr. Robinson has run through. Thank you all.
Great. Thanks so much, Dr. Zahn. So Dr. Robinson, why don't you unmute? Dr. Zahn, stay on unmute. I'll go through the questions really quickly. I think we saw, so if a person gets first vaccine, then gets COVID, do you get the second vaccine on the scheduled date, Dr. Zahn?
Yeah, absolutely. Yeah, we've had several people, unfortunately.
Yeah.
You got the first dose, then you get COVID in between. As long as you wait those 10 days, right, till you're non-infectious, getting the second dose is entirely appropriate.
Right. And so that was a similar question on that. Let's see, some issues. What is the vaccine recommendation for patients with anaphylaxis history? Should vaccine be given in hospital setting? I think he just covered that. You're going to want to, everyone who's doing this vaccine should have an emergency kit and have folks who have a history of anaphylaxis wait for 30 minutes. Dr. Zahn, anything to add to that?
Yeah, I mean, no, exactly, Helene. The one comment I'd have is for all of us to kind of go, for me, I go, well, should they be seen by like an immunologist or in the ED center or something like that? And, immunologists or allergists will point out an awful lot of people out there have a history of these sorts of things. So it doesn't mean it needs to be totally separate or specific hospital or immunologist or anything. Just really be aware, watch them for 30 minutes and have epi ready.
Okay, great. If a patient had the vaccine, then got COVID in between the two doses, would they be eligible for the monoclonal antibody treatment, Dr. Robinson?
Sure, I'll take that. So the guidance from the CDC states that if you get a monoclonal antibody, it's best to wait for 3 months from administration of the monoclonal antibody because those monoclonal antibodies will probably decrease the efficacy of that vaccine.
Right, but the question is actually if someone had one dose, then gets COVID, they can still get the monoclonal antibody, correct?
Absolutely, absolutely.
Right,
and I would wait for 3 months. I would wait 90 days after the monoclonal.
Yep, okay. Let's see here. What's next? We will be sending a link with all this. I think Dr. Zahn covered how medical providers can receive vaccine for their patients. We can't tell you when. What is the rationale for CDC recommendation to avoid acetaminophen or NSAIDs prior to immunization, Dr. Zahn?
Yeah, so it's a good question, and there was a fair amount of talk about this at the ACIP when they voted on this. There is some circumstantial evidence for other vaccines that if you take an anti-inflammatory, NSAID, or if you take acetaminophen, that people's antibody titers may be somewhat lower after the vaccine. This is not COVID study. These is other vaccines. So there's at least the theoretical concern that if you work too hard to modify, you could slightly modify people's immune response. So with that theoretical reason, they said we don't want to routinely recommend that it happen in everybody. Now, I would say that the CDC definitely says if you get those aches and pains and you get fever and if you're feeling miserable, they say talk to your provider about it, but essentially it's not unreasonable for people to take those to take NSAIDs or acetaminophen if you have those symptoms that we're seeing after vaccine. That's certainly acceptable.
Great, thanks. Dr. Robinson, do you recommend to use Mask Plus and or IFL-CCC treatment or prophylaxis?
Use what?
Mask Plus and or IFL-CCC treatment or prophylaxis.
So I'm not sure what those are, so I do not recommend those until I know what they are.
All right. Okay, let's see here. Wondering why there's an increased cardiac arrest with commonly used hydroxychloroquine alone. Do you think this has to do with the treatment or the virus itself?
Super good question. It's probably a combination of effect of the compound on cardiac conduction as well as COVID possibly also affecting the heart and its conduction as well. Hard to know for sure. Great,
thank you. Dr. Zahn, how long should we stay away from steroids post-COVID vaccination if patients have asthma and have a flare after a dose? Should they not give steroids?
Yeah, so it's not a live vaccine, so there isn't a contraindication or particular risk for it. If someone's having a significant clinical issue, it's all as a balance, but, I guess as a pediatrician who hasn't actually treated asthma for years, but if someone was having a significant attack and they needed steroids, I wouldn't say, oh, you got a vaccine, so you can't do it. It's perfectly acceptable to do. There's no risk, again, because it's not a live vaccine. In terms of potentially moderating the response to the vaccine because of steroids, there is at least, the CDC hasn't really said anything specific about COVID, but I'll just say from a pediatric ID side, for most vaccines, if you've gotten 2 weeks or more of 2 per kilo or more steroids, so for 2 weeks or more of a significant dosage, it would make sense to hold off on vaccinating. The standard thing is to hold off for a month. So, before you receive the vaccine. So it's not like there's no issue there, but again, it's not a live vaccine, so there isn't a contraindication. And if someone's received the vaccine when they've been immunocompromised, there isn't a recommendation to restart the series, so to speak.
So if someone has required a course of steroids, you would consider delaying either the first dose or second dose for a month if possible?
Yeah, I mean, I think that what the standard thing, and again, this is a couple things. There is no specific CDC guidance on it, right? I think that if someone has received, it's not this is the pediatric ID side of me, but if you've received 5 days worth of steroids, that's not really considered significantly immunosuppressive. That isn't a deal. If you've received 2 weeks or more of a high dose steroids, then you are thought to potentially be somewhat immunosuppressed. Out of an abundance of caution, you may wait a month to give that dose of vaccine to make sure your immune system is primed and ready to get the vaccine.
Great, thanks. Many would like to know, is there any data on whether the COVID vaccine 5% failure rate is due to lack of antibody response and could be detected by drawing antibody titers afterwards, like we do after giving hepatitis B vaccines to see if there's protective antibodies?
Well, so 5% failure is, okay, what we know is that it seems like you are 95% less likely to get COVID, comparing the people who got vaccine in the trials compared to the people who did not, right? So why that is not entirely clear. For coronavirus immunology, it's not as simple as you generate an antibody and therefore you are immune. It's a combination of antibody generation and T-cell response. And so I think it's something that they're aggressively following on all the people who are in the trial. As they get more data, they're probably going to learn more about what that failure means in terms of their immune response. But it's not a simple thing to do. And no, I don't think that routinely checking antibodies after someone's been vaccinated is going to be terribly clinically helpful for us on a regular basis.
Great, thanks. A couple of questions about Bell's palsy. Bell's palsy occurs after vaccine dose number 1. It's thought that really the occurrence in the trials was not necessarily worse than it is expected at population baseline. But what would you say if someone gets it after dose 1? Would you give dose 2?
Oh, glory. That's a tough one, man. We all, if you paid attention to the FDA advisory, the FDA when they were recommending the vaccine, everybody said, boy, that's kind of funny. How come, but literally it was like 3 people in the vaccine arm out of 15,000 got Bell's palsy, and 1 or none in the placebo arm got Bell's palsy. There really isn't. There is a background rate of Bell's palsy, and so the FDA and the CDC have really concluded it's not clear that there really is an association there. It's more if you give tens of thousands of people any treatment, they may get Bell's palsy afterwards. Now, if it was in my office and someone got Bell's palsy, in the days after the vaccine, boy, that's a conversation with the person and to think it through. There isn't obvious guidance on that. The FDA and CDC guidance is it's not clear that there is a relationship. On the other hand, you see the data, and as a clinician, it's not the craziest thing, I would say, to say, man, maybe I'm not going to give the second dose, depending on the situation. Relatively healthy person, low risk, not a healthcare worker or anything like that. It's not a crazy thing, but there isn't specific guidance. And I do think the CDC this is one of those where the CDC is looking at their VAERS system, the Vaccine Adverse Events Response System, reporting system, to see if over time, as we're given hundreds of thousands of doses in this country, is there evidence of Bell's palsy? I'd say, definitely stay tuned. We hope to have more information on that.
Great, thanks. Dr. Robinson, several comments about how it's really hard to send someone to an ER for anything in regards to monoclonal antibody treatment, but you mentioned there are infusion centers. Is there a way that someone can find out where these infusion centers are? And what kind of side effects can be expected with monoclonal antibody treatment?
So side effects, the major side effect is an anaphylactic reaction, and it occurs in about 1% of patients. I have tried to find out exactly where these infusion centers are. Some of them are associated with hospitals. I don't want to name names because I don't know whether or not they have the capacity to take an onslaught of patients. But there are several of the acute care hospitals where emergency rooms do have protocols in place to administer these compounds to at-risk patients. And if they don't have the capacity, they have the capacity to refer to one of the infusion centers. There may be people who are listening now that know of the location of an infusion center. They could type it in the chat.
Great, thank you. How would you address an outpatient demand for ivermectin who states the data suggests it might be helpful? Why shouldn't they be able to get the medication?
So the data for and against ivermectin are flawed. We do not know whether or not ivermectin provides any benefit to patients, and certainly it's not without risks, as we talked about. Many patients demand this, but it is important as clinicians that we help guide our patients to make sure that they're looking at good sources of information on the internet, make sure that we have time to sit down and explain the pros and cons. If a prescriber still wants to prescribe ivermectin to a patient, which would be off-label, unapproved use, there must be a very, very detailed discussion documented in the patient's medical record about the risks and the benefits, so that you reduce your legal risk at a minimum. But I would spend the time with your patient, explain the state of the literature, explain why what they see on the internet may in fact not be true, and help them go to reputable sites for better information.
Great, thank you. Can you give further guidelines regarding who can possibly use monoclonal antibodies, as the over 65 is a very large group for a limited supply of drug?
That's correct. Well, the EUA allows us to give this to many more people than just the ones that I mentioned, over 65 or a BMI greater than 35. There are multiple other immunocompromising conditions and medical comorbidities, so it's very broad. In many of the infusion centers, they've decided to select really just those people that are most likely to benefit from it. In particular, since monoclonal antibodies are not, the supply is not unlimited. So we are choosing, for example, to just go with those groups. And within those groups, you need to prioritize as well, depending on the amount of supply that you have available.
All right, thanks. Let's see. Any benefit for use of inhaled steroids?
Unknown.
Okay, unknown, thank you. Has anyone used RLF 100/avaptidil for severe critical COVID-19 patients in the ICU through the FDA's EUA program?
So we have not used that at our acute care hospitals, but I'm sure somebody on the phone may have had experience with those. I don't have experience with that.
Okay. There's questions about getting vaccine to homebound elderly. We really don't have a good answer for that right now. There's a question about, with shortage of vaccine, should a person who got Moderna be considered for Pfizer's second dose? You're supposed to stick with the vaccine type you started with, right, Dr. Zahn?
Yeah, that's correct. Anecdotally around the country, we've run into someone is working at one medical center and they move clear across the country to another medical center and they just can't get the other, the type of vaccine they have. On selected cases, I think people have elected to give the other dose. And that's not considered, completely wrong. But if at all possible, get the second dose of the same vaccine.
Okay, Dr. Robinson, and comment on the use of H2 blockers in treatment of COVID.
So the data does not reach the level of the recommendation. The data is very unclear on whether or not H2 blockers affect the disease course at this point. So we do not typically recommend them, and we do not use them as part of our protocols.
Okay. There's a few comments about volunteering to help out with the pods and other things. Dr. Zahn, do you have any information? I know there's a form and people are supposed to submit it.
No, that's a really good question. Let me hot quick see if I can find. And there's a on our website. There's a site you can go to. In fact, I mean, if people go to OCHCA, if you look us up on their website and you look under vaccines, there is a place where people can go to that they're asking for volunteers. So, Dr.
Zahn, if you're still sharing your screen, if there's any way you can get that link up there, as well as people were asking for a phone number. The phone number that was the hotline that was just put out for elderly folks who are not tech savvy to try to get an appointment. If there's any way you can put those things up on your slide right now, since we're still recording, it'll be on there, or we can push that information out afterwards.
I will do that as quickly as my slow county computer allows me to access the internet.
Yes.
I will comment though, Helene, I think to be totally clear here, while we have a phone number out, I wish that phone number was a phone number that would allow you to make an appointment. That's the phone number. The phone number allows you to basically is information. People have questions about the process. It's not one that can. So I don't want to give the impression you can call this number and they make an appointment.
And let me say that Dr. Zahn and I had nothing to do with this whole thing.
That's we're all in this together, Dr. Calvé. So I'm not,
I don't know.
That's not how that's not how the world works. So let me see. Give me.
All right. While you're doing that, let me go down
yourselves, and I'll try and find.
No. I'm gonna find some more. There's questions about getting. How to get the mobile clinic. I'll also find the vaccine, the COVID vaccine clinic of emails that people have these questions about. How can they register? How can they get mobile vaccine clinics? I don't think those things are happening yet, but just so that they have that information for the future when they're supposed to happen. Let's see.
That's
and I
correct.
think there's a couple questions about people that got first dose. They should be, I think they're prioritizing getting second dose. So, hopefully that'll happen.
It sounds like Cherry bailed me out and put in the chat line the link for volunteering. So shout out to Cherry for bailing me out on that one.
Here's a good one. Different COVID topic. Is there any information that these variants that are thought to be more transmissible, is the time of shedding of infectious virions found to be any different, changing the isolation period? I don't think there's any data on that whatsoever. Are you aware of any, Dr. Robinson?
No.
I can tell you that our experience from the SNFs is that something changed between first and second wave. We were seeing many, many more outbreaks with very high attack rates. 80, 90%. So clearly it seems transmissibility has changed. We're waiting to see about whether this variant that was detected in Santa Clara, it definitely is here, was found in some of our SNFs. And we're waiting to see from our outbreaks in December whether it's the dominant sort of strain now or not. But there's just not.
I agree with Dr. Calvé. I think that the one thing I'd emphasize here is that, one, our surveillance capacity, unfortunately, to identify these variants is not what we'd like it to be. For thousands of cases that are reported a day, there are a few laboratories out there who do the type of laboratory testing that identify the quote unquote S-drop type viruses or pattern from PCR that would tell you that the variant is here. I would guess that the UK variant is likely here in Orange County. It is definitely south of us in San Diego County. I would note that from CDC conversations, with San Diego talking it through, and on an international level, there really isn't a difference in guidance in terms of, thought infectious period. Do you do N95 or infection control or length of isolation or quarantine differently? None of those recommendations are different at this point with these variants. But certainly we're trying to gather as much information as we can. Down in San Diego, they're doing a case control trial looking with the CDC to see if there's any evidence that these people behave clinically differently. So far, there isn't a lot of evidence that they're obviously different, but
Right.
more to come.
Well, this is different than the UK variant. I'm talking about the L453R that was detected in Santa Clara.
Yeah, no,
So-
that's true. But I'd say for that one, Helene, we have even less evidence that that it's something totally different. Doesn't mean it's not a problem. These are all really worrisome to us. But for clinicians out there, wouldn't say, hey, we're gonna treat these or give different recommendations for these. We're all worried. We're trying to get surveillance and follow up as soon as we can, but we don't have evidence to say different right now.
Yeah, thanks. Although epidemiologically, it sure appears something changed. A couple questions about why would someone who recovered from COVID get vaccinated since they haven't been studied, and ample evidence that immunity lasts at least 8 months. Dr. Zahn, you want to address that?
Yeah. So if a person takes this information and said, I don't feel like getting vaccinated, in general, I think that's a very reasonable response. I think that, again, in certain situations, such as someone's working in a skilled nursing facility, or if you're working in an ICU and you're around critically ill patients over time, we do know that reinfections occur. I mean, they definitely happened. They've been very unusual. Totally get that. But I think we also have ample evidence that the vaccine is pretty dang safe. And I'd also say, the next thing I'd also say too is that we know that the vast majority of people who were infected with COVID in our county, probably including healthcare workers, they don't know that they've been infected. So we're vaccinating an awful lot of people who have had COVID in the past. There's no evidence that having had COVID in the past causes a risk or poses a risk for you to get vaccinated, and reinfection events do occur, admittedly, very rare, but it seems to me quite reasonable to get yourself vaccinated. Yes, there's other data, and reasonable minds can look at this and go, no way, I get that.
Especially if someone does, we've had experience in the SNFs where a handful of what I think were real reinfections weren't able to prove any of them because we didn't have both isolates to do whole genome sequencing on, et cetera, but seems to be folks 3 to 4, maybe 5 months out who have a second intense exposure, either in a household setting or another outbreak in the SNF. And not real common, very, very rare, but is happening. Okay, Dr. Robinson, any thoughts about quercetin and lysine?
No data.
Okay. Let's see.
Hey, Helene, can I answer one? Someone sent me an email, but it's a great question.
Sure.
The question is, if you've been vaccinated before, can you be a carrier of the virus? And it is the $1 million question. It is one we don't have the complete answer to. So in other words, we know that the vaccine's really good at keeping you from getting sick. Does it keep you from acquiring the virus and being potentially infectious to other people? It's a very hard thing to study, right? Because when people get vaccinated and have no symptoms, when do you test them? So it's hard to get great data. The evidence so far, which is limited from the vaccination trials, says that you seem to be less likely even to have asymptomatic infection if you're vaccinated, but that's far from saying it can't happen. So, for now, it seems unlikely. We're waiting for the CDC to give us some guidance on that because, for example, if you're getting tested every week for COVID, because of your work site, you work at a hospital or whatever, and now you've been vaccinated, do I need to keep getting tested every single week? If I'm at a nursing home, do I need to get tested every single week? It's a big question. That data out there is not conclusive, but the CDC is thinking real hard on it, and we're probably going to get some specific guidance about that.
Right, and time will tell, because right now SNFs in Orange County are having to test all their staff twice a week. And now we've had about 10 SNFs that have gone through their second round. So it'll be really interesting to see what happens
Yep.
2 weeks after this. Really
Yep,
quick, Dr. Zahn,
absolutely.
how long do you have to delay in receiving COVID vaccine if you received a different recent vaccination?
2 weeks before, 2 weeks after. There's
All
no
right.
absolute proof. It's best guess. Science, the CDC says. If for some reason you have to, for whatever reason you have an emergent vaccine need, the CDC says it's probably fine. But unless you need that, wait 2 weeks, separate the two vaccines by 2 weeks.
All right, Dr. Zahn, what if someone had one of these angioedema reactions or some other severe reaction, severe rash or whatever to first dose? Would you give second?
Yeah. I will tell you, having talked about these, for example, the events down in San Diego, when we talked to allergists said, I don't know, we'd be okay with them getting a second dose, but those are allergists. I think that if you had an event like that situation probably would be one to talk to an allergist, immunologist about the situation. So not a contraindication, but one you want to think hard about. You want to think hard about that one.
All right, and really quickly, when a person has been, a healthcare provider has been exposed and is quarantined, could they consider getting the vaccine or wait until after quarantine period?
Yeah, I mean, for healthcare workers, the difficulty, if you are someone who is the short answer for the CDC is the only reason not to get vaccinated is if you know that you are, that you have COVID during the time. They really don't say anything about quarantine. That's particularly for healthcare workers. Unfortunately, the world we're living in right now, we have an awful lot of healthcare workers who are having at least potential exposure to COVID on a really regular basis. And so it is not a contraindication to get vaccinated.
All right. Should you stop low-dose aspirin before taking vaccine?
I haven't seen anything that anybody says you're supposed to do that. So
Okay.
I don't think there's any guidance saying you're supposed to do that.
There's questions about vaccine and pregnancy, immunocompromised. I think it's fine to give those people, right, Dr. Zahn?
Quite so.
Yeah. Let's see. Someone asked about stats on healthcare workers compliance. I don't think we have, or uptake of vaccine. I don't know that we have that personally. I'm going to hopefully get that information, at least from SNFs who are going to be reporting it.
Yeah, that's right. And of course, there's limits on the vaccine out there. So if you're hesitant, it's pretty easy for you to hesitate because it's just hard to get the vaccine right now. I do think that the enormous surge in disease that we've had recently, I think that's probably driven a lot of people to say, hey, maybe I want to get vaccinated. But there certainly is hesitancy that's out there, and we're thinking through how to address it.
Okay, so people have posted links to the eye mask prophylaxis treatment protocol. I'm not sure what that is. Also to our pod flyer, volunteer flyer, the hotline number. That's all in the chat box, so check that out. I'm getting down towards the end, and I think we should probably wrap this up. It's almost, although thanks for hanging in there. We've got almost 290 people who are still hanging in. Athena issues, yeah, sorry. Any other contraindications besides anaphylaxis? No, I guess just allergy to any component of the vaccine, correct?
Yeah, no, that's right.
We don't know how well the vaccines are going to protect against variants. We think that it would probably be pretty good, at least as far as we can tell.
Yeah, no, that's right. And on an international level, they've been looking at in vitro response for to a variety of different variants that are out there. Not necessarily, and it seems encouraging, but we shall see.
Okay, and okay to give vaccine if someone's on anticoagulation. Yep. Okay. There's current recommendations, those who are considering getting pregnant or are pregnant. Yeah, well, that's fine, right? Yep.
There's a higher, there seems to be a higher risk if you get COVID if you are pregnant. It's not a live vaccine, so there's a good physiologic reason not to get the vaccine, and you're in a higher risk situation. So.
All right. Well, I think that's it. Sorry, I don't know about the second dose. Any age limitation to get vaccine over 95? I don't think so, right?
I don't know. Stop when you're at 150. No, yeah, there's no. 16 and over for Pfizer, 18 and over for Moderna. No, yeah.
All right, great.
And evidence is that even in an elderly man, it seems to work really well. So I think that's encouraging for us.
Great. So thank you all very much for hanging in there. Sorry we went way over time. I think we just had too much good information to try to pack into an hour. Next time we'll know to allot extra time. This will be recorded. Link will be posted. It'll go out again through our constant contact provider list. So thank you all. And thank you so much, Dr. Robinson, for your wonderful presentation. Dr. Zahn, for your expertise. Forgot to mention that Dr. Zahn is on our state's vaccine safety task force. And in addition to the link to the recording, we will post a PDF of the slides. Thanks so much.
Thank you all.
Thank you.
Thank you.